We're live. Howdy. Thanks for learning about MS with me, Aaron Boster. I just got home from a really long trip. I was gone almost 2 weeks. It's nice to be at home. Folks are upstairs asleep, and I wanted to jump online and say hello, howdy, hi to all you guys. I'm hopeful that there's some folks that feel like joining in and chit-chatting with me. I thought that I would answer some questions about MS and just see what everyone's up to. Amanda's here. Hey, Amanda, how are you? AJ's HR is here. What's up? Raven's jumping online. Rev is here. I got Blake here. That's kind of fun. Hey, Candy, how are you doing? Hello, Sherry. Hey, Mama Jojo. Some people are jumping online. This is fantastic. I love this. Making sure that the camera works. I'm not sure that all the buffering problems are still worked out. So as we're doing this, please give me some feedback if you're noticing that the connection's not very good or the buffering's not working too great. I thought today we would just do an Ask Me Anything. I haven't prepared a topic. I just got home from a really long trip overseas, and I really wanted to hang out with you guys. As always, a couple things to keep in mind. Please share with me where you're calling in from. That's always really fun for me to see this growing global online community and to see where everyone's calling in from. I got folks from Cleveland, Michigan, Wilmington, Missouri. This is fantastic. Hello, got folks from LA. And as you ask me questions, please start the question by all capitals writing question. That makes it easier for me to find the live stream. I'd also ask that you make sure that the question is kind of a general question, something that would apply to everyone, because I can't provide a diagnosis or treat you on the interwebs. That just doesn't work out. So keeping that in mind, let's see what we've got cooking. I'm going to go to the live stream and try to read this. I got Larry from Ohio calling in, and he says, I have terrible pain in my legs when I walk. What do you suggest? Larry, there's a lot of different reasons that people with MS can have leg pain. And it's going to take some careful questioning with your clinician to try to figure it out. You could have leg pain because of spinal cord injury from MS that's causing what's called dysesthesia. That's a fancy doctor word for the nerves are getting the wrong impulse, and it can feel like a burning or an aching or a cold pain. Typically, it's in a part of your leg or your foot. You can have pain from spasticity, from really tight muscles. You can have pain in your legs because MS makes you walk in a funny manner, and it's putting stress on your joints. There's a whole host of reasons that you can have leg pain. You also can have leg pain for reasons that are not related to MS. So my recommendation is you bring that to your clinician and you engage in a conversation, let them take a careful history where they'll try to piece out stuff that may be going on, let them do a proper neurological examination and get to the bottom of it. The good news is most of the time we can treat neuropathic pain. So you don't have to live with the pain that you're having. You just got to bring it to your clinician's attention. Reading through some of this, I got some questions popping up. This is fantastic. And also, guys, remember, if I don't get to your question during the live stream, I read through all these and I copy and paste them. I'll either answer them in a future live stream or I'll make an entire video about your questions. So don't fret if I don't get to it this time. All right, let's look for some questions. Why is the damage localized versus everywhere? Is there myelin? This is a question from Keith. So Keith, the most common form of MS is relapsing MS. And early on, at least the first half of the disease, we see acute focal bouts of inflammation. So when you get an MRI, you'll see a white spot, and you point to the white spot and say that's a spot or a lesion. The reality is that MS affects the entire brain and the entire spinal cord. And when you look at MRIs, we call the white matter normal appearing white matter. And we call the gray matter normal appearing gray matter because we know that metabolically that tissue is not as healthy as it could be or should be. And so, in fact, MS does affect the whole brain and spinal cord, and there can be focal bouts of inflammation. The MRI doesn't show you everything. The MRI shows you only part of the story. It's a very, very helpful tool, but it doesn't show you everything there is to see. That's a very good question. Catherine writes in, question from Boston. Well, hello from Boston. Can you talk about any new Ocusys long-term data that you saw at ECTRIMS? Yes, I can. So we now have, I think it's 6.5-year data. There's 120,000 people worldwide that have been treated with Ocusys. And the punchline to the long-term data is that we don't see any new signals. We continue to see really impressive suppression of MRI activity with Ocusys. We continue to see really low relapse rates. And we haven't seen any new safety signals that I haven't already talked about on my channel. The one thing that maybe was brought out, and I talked about this in my last live stream, but I like to bring it up again, is that for some people, we can see a dip in their IgG or IgM levels. Now, what the heck's an IgG or an IgM? It's their antibody levels. They can dip down a little bit. That's not common, but it can happen. And it might slightly increase the risk for infection. And so that's not really new information there, but there was a poster on it at ECTRIMS that caught my attention. So the punchline is that what we know about Ocusys has not seemed to change. We haven't seen any new safety signals, and I like that a whole lot. So that made me feel pretty darn good. MS Water Challenge, when I drink, you drink. Drink up, guys. All right. Let's look for some other questions. Here's a question. Is there any help for cognitive issues? It's affecting my work and I'm afraid of getting fired. That is a very, very real concern. The number one reason that people end up leaving the workforce because of MS is not because of difficulties walking. It's because either of cognitive impairment or pathologic fatigue. Now, I have a playlist on this channel where I have, I don't know, probably over 15, 20 videos that I've done on cognitive impairment in MS and things that you can do. And so for starters, I would encourage you to go to that playlist and watch some of those videos, if not all of them. But to give you an answer here live, yes, there's a lot that we can do to treat cognitive impairment. So let me try to come up with 10 things that'll help cognitive impairment just off the cuff. The first one is that we need to treat depression. If you have depression and it's not being treated, it will impact your cognition. There's a special term for that. It's called pseudo-dementia. And it's a phenomenon that I see all the time. Sometimes people feel a little depressed, but they're not super gloomy and doomy, and they think, oh, well, that can't be the problem. But I'm telling you, if you treat the depression, the cognition improves. So that's number one. Number two is that we need to look critically at the medicines that you're taking. For example, many people with MS have bladder problems and they're put on a bladder pill. The most common type of bladder pill is a medicine that's an anticholinergic. That's a type of bladder pill, anticholinergics. And those are notorious for causing cognitive impairment. Similarly, if you're being treated for pain with pain medicines, if you're being treated for spasticity with spasticity medicines, that can cause cognitive impairment. So looking critically at your medicines can be important. Number three would be to be cautious about recreational drugs and alcohol, because a lot of those recreational drugs and alcohol can impair cognition. For example, cannabinoids, marijuana, ganja. Marijuana can have a negative impact on cognition. And so paying attention to recreational drugs is helpful. Number four, we'll just talk about medicines. There's a host of medicines that are prescription medicines that can trick the brain into being more awake. And so those are medicines like Nuvigil or Provigil, or stimulants like amphetamines can make a really big difference. Another one is using levocarnitine. Levocarnitine is an amino acid that can help with energy levels. I find that can help a tremendous amount in cognition. Number six is to get adequate sleep. So a lot of folks don't get 8 hours of sleep. You know, they try to get by on 5 hours, 6 hours. And what they're doing is they're depriving themselves of adequate sleep. And so they're making it much harder on themselves because they're not getting enough sleep. So if you're not sleeping enough, that can make a big difference. Number seven would be to make sure that your sleep quality is okay. Are you a snorer? Do you have obstructive sleep apnea? Are you waking up multiple times a night to go to the bathroom? Do you have restless leg syndrome? So I just actually listed a bunch of things, but they're all under the auspice of managing the quality of your sleep. The next one would be to take a nap. Naps are awesome. And a lot of people with MS, they have cognitive impairment as the day goes on. They become cognitively impaired and they have trouble thinking as the day continues. And so taking a nap is like a reset. That can help a lot. The ninth thing would be to exercise as part of your lifestyle. This is really, really important. If you can exercise as part of your lifestyle, you'll find that you actually have a better sleep quality and that it can improve cognition along with energy levels, along with depression. So exercising is really key. The last thing is there's other reasons why people can have sleep problems. Other reasons why people can have cognitive impairment. And you want to make sure that there isn't like a metabolic problem going on, that you have, for example, like an abnormal thyroid. So my point here is you want to look beyond just MS for why you might have cognitive impairment. I'll throw in an 11th one just because we're naming stuff. And you can work with a speech pathologist. Speech pathologists are really, really good at helping people rehab their cognition. So there's 11 tips off the cuff that can help with cognition. That was a great question. Thank you for asking it. Let's look for some more questions. So Cheryl writes, question, Dr. Boster, hi. What do you know about dosing CBD? I don't. CBD has been very poorly studied in MS. There's a profound positive information about it. That doesn't mean that CBD doesn't help people. Anecdotally, it certainly, I have plenty of patients that tell me it does, but I haven't had any formal education on how do you dose CBD. And so I'm sorry, I can't help you there. Sitting in my chair, question, what does Copaxone do to the body? Copaxone is one of the MS medicines. It came out in the mid-90s, and it's a self-injection that you take thrice weekly. By the way, I love the word thrice, so 3 times. So 3 times a week, you give yourself an injection. This is my pretending to give an injection. That's not how you do it. And Copaxone is a chain of 4 amino acids. Glycine, leucine, arginine, and I think tyrosine. So there's G, L, A, and T. And they're in a random order, and they're in different ratios. That's a secret. That's a company secret by Teva. And that ratio of amino acids mimics myelin. So that's the fatty coating on the nerves. And that's actually one of the targets of the autoimmune disease MS. And so what you do when you give yourself Copaxone is you inject yourself with fake myelin. And you're showing your immune system its target. You're saying, hey, immune system, look at this. And then a couple of days later, you give yourself another injection and say, hey, immune system, look at this. And you keep showing your immune system its target. And literally, the immune system kind of becomes bored of myelin. So then when the immune system sees real myelin, it says, I saw that yesterday, I don't really care. And it's a way of creating sort of a peripheral immune tolerance is the fancy pants term. But what it does to the body, aside from desensitizing your immune system, is darn near nothing. It's a chain of amino acids. So Copaxone doesn't cross a cell membrane. It doesn't bind to a receptor. And it's not really something that needs to be metabolized by your liver or by your protein. So it's in my opinion, one of the safer products that we can give people. It's safe to give people Copaxone if they have MS and they're pregnant, in my opinion. I've used it in people that have MS and HIV or MS and cancer. It's a very safe product. Now, you can have some skin issues with Copaxone because you're jabbing yourself with a needle and it can cause a welt and it can itch or it can hurt. It can leave a big welt, and that can be unsightly and unpleasant. And if you take Copaxone for a long time, or I should say, if you inject yourself for a long time, it could be with anything, you can get what's called lipoatrophy, where there's actually a divot in your subcutaneous fat from jabbing yourself with a needle. That can help. That can happen, for example, with folks that have to take insulin shots. But Copaxone is, in my opinion, a rather benign substance. Good question. So Kitty White writes, how do you know if we've progressed from RRMS to SPMS? So RRMS, relapsing multiple sclerosis, and SPMS, secondary progressive MS. So first of all, it's a spectrum. It's not like stage 1 and stage 2. It doesn't really work like that. Both are relapsing forms of MS. And I want to point out that people that have secondary progressive MS can still have attacks. They may not have them as often, but they can still have them. And they tend not to recover from them as well. And I bring this point up because I don't want people that have secondary progressive MS to stop taking MS medicines. I think that's a huge mistake. And so I think it's really important that if you have a relapsing form of MS, that you're on a therapy to treat relapsing forms of MS. Now, how can you tell? Well, there are some definitions that can be applied, and they're not straightforward definitions. So for starters, you have a history of having relapsing MS, all right? And then you have had progression of disability in the absence of an attack. So an example would be the last time I had an attack, doc, well, I don't even remember, maybe it was 7, 8 years ago, maybe even longer. But my walking has progressed over the last year and gotten worse and worse. A year ago, I was playing 18 holes of golf, and now I don't think I could play 9 holes of golf, and I've really limited my ability to walk. And there are some definitions that talk about the exam and what you see, but the flavor of SPMS is someone who is not having frequent attacks the way they might have 10, 20 years ago, and they're starting to have progression of their disability independent from attacks. The progression is not fast. It's not over days or weeks. It's even slow over months. So I would typically look over a span of years when I'm trying to assess if I think someone has secondary progressive MS. But I'm going to state this again, that just because you have secondary progressive MS doesn't mean that you shouldn't be on MS medicines. You still should be on MS medicines. I firmly believe that it's important for many reasons. I actually have some videos on my channel where I talk about why I think it's important to keep treating MS, even if you've transitioned into SPMS. That's my 2 cents. Ladia Blake writes in from Baltimore. Hey, how are you? Are there any connection between epilepsy and MS? Well, yeah, kind of. People with MS have lesions on their brain, including the cortex, the surface of the brain, and that puts them at increased risk of having seizures. So in some studies, it looks like people with MS are 6 times more likely to have seizures than the general population. Now, fortunately, most seizures are easily treated with a pill. So you can take a medicine a couple times a day and knock the seizures out of the park. Now, there aren't other associations that I'm familiar with. So it's not like if you have epilepsy, you have an increased risk of MS. I don't think it works like that. But amongst people that have MS, yes, there's an increased risk of having epilepsy. So Jenny Mortal writes in, any news on remyelinating meds? Jenny, that is a great question. As many of you know, I just got back from the ECTRIMS meeting where there was a lot of talk about remyelination. I was very excited about the buzz about remyelination. And I would submit to you that we're probably about 10 years off from having a remyelinating agent. There's a lot of studying going on. It's tricky stuff. Really what you're trying to do is you're trying to get a baby oligodendrocyte. That's the cell that coats the nerve and makes myelin. You're trying to turn it on and make it remyelinate. And that's a really challenging thing to do. There's a lot of very early work going on. We're not there yet. It is a big thrust, a big effort. There were a lot of really cool discussions about remyelination, but we're not there yet. So stay tuned. You might think, oh gosh, 10 years, that's a really long time, but it's really right around the corner. I'm talking about, it's my prediction that in 10 years from now, we'll have a remyelinating agent that we can prescribe to someone. So stay tuned. So Chris C writes, should your annual MRI do both the brain and the spine or just the brain? That's a really good question. The consortium of MS centers, of which I participate in, recommends an annual MRI of the brain and only doing a spine when you have new symptoms attributable to the spine. Now, I think an annual brain MRI is a really good idea. I think it's important to get a spine probably every couple years. I don't get a spine every single year, but I do like to get at least a cervical spine maybe every other year or every 3 years. I think it's good to look at it. And so I don't do it every year, but I do it every couple. Now I see Sally writes that you're cutting out bad. And guys, let me know if this is cutting out really bad. Let me try to skip down and see. Is anyone else noticing that it's cutting out really bad? You know that I've had some problems with my connectivity. All right, so Jacqueline Bernard writes, hi, Dr. B. Well, hello, Jacqueline. I really had hoped you'd answer my last questions posed. Suffering terribly alone. Please, any believers out there, I much need prayer. So I didn't see your last question, and I'm not sure where it is. Sorry. I'm not sure. If I find it, I'll definitely try to answer your question. I'm scrolling through right now trying to find it here. So Angela Marcus writes, question, how does Ocusys work compared to other MS medicines? So I have an entire playlist on my channel on Ocusys, including some videos on how Ocusys works. Ocusys is an antibody which targets adult B cells and kills them. And by killing the adult B cells, it interferes with B cell T cell communication. So the B cell is needed to get the T cell riled up to go attack you. And if you knock the B cell out, then the T cell can't do it by itself. And I have an entire video where I kind of describe that in a manner of speaking. So there are now several other B cell agents that are being studied. At ECTRIMS, there was a big to-do about a new drug called ufatumumab, which is another B cell killer. There's a medication that it's not approved for MS, but it can be used for MS called rituximab. That's a B cell killer. And those are an entire family, a class of medicines that knock out B cells. So that's one small sliver of your immune response. And in your question, you asked, how do they compare to other medicines? Well, we've only done a clinical trial with Ocusys compared to Rebif. So Rebif is one of the original interferon medicines, been around since the early 90s. And compared to Rebif, Ocusys destroyed it. It really was a big, big difference in the ability to decrease relapses, to slow disability progression, to improve outcomes on the MRI. It was such a stark difference that I do not understand why doctors still use Rebif. In my mind, there's zero reason to use Rebif. We now have class 1 evidence that there are better medicines, and Ocusys is an example of that. So Kitty Wright writes, question, if I've been 26 years untreated, will treatment help now? Well, I can't answer, Kitty, for you because I don't know your history. I haven't examined you. I haven't looked at your MRIs, but it's my opinion that we want to treat people that have MS for the duration that they have MS, which is for their life. And so if I were to see you in clinic, very likely I would want to put you on a therapy. You still have a brain, you still have a spinal cord, it still works, it could become damaged. And so I would want to do everything possible to try to preserve the reserve. Preserve the reserve, the neurological functional reserve that you have. And one of the best ways I know how to do that is by putting you on a disease-modifying therapy. And I might as well bring up my concept of being 4 for 4. Many of you that participate in the channel are familiar with my saying that I want you to be 4 for 4 in your fight against MS. So one of the things is to exercise as part of your lifestyle, don't smoke cigarettes, eat clean and supplement low vitamin D, and take an MS medicine. And that's true whether you've had MS for 26 years or not. So that's just my 2 cents. What else is cooking here? Let's look for some other questions. Here's a really good question. Kathy Foss writes in, Dr. B, sometimes could you do a whole segment on older MS patients like 60s and 70s? There's a lot of us, and we often get overlooked in the clinic setting, or doctors don't want or like to treat us. That is a great idea. The answer is yes, Kathy. I will absolutely do that. It's true that some MS doctors inappropriately dismiss older MS patients or send them back to their primary care doctor. And I absolutely hate that. I think that's ageist. I think that's a cop-out. And I think that we really need to dig in. There's lots to be done to help someone who has MS and has reached their 60th or 70th or even 80th year live a very, very full life. And managing symptoms and improving quality of life becomes very, very important. And so I would love to talk about that. I'm sorry, guys. I just got back from Europe literally this evening. In Ohio, it's almost 10 o'clock. So 11, 12, 1, 2, 3. So it's 4 o'clock in the morning in Europe time. So it's like I've been up for a long time now. So I apologize for yawning. But Kathy, yes, I think that's a great topic. I will be thinking about that, and I'm going to come up with either a live stream dedicated just to that topic, or probably a video that I'll record and post on this YouTube channel about addressing concerns of older people with MS. You know, another really interesting and important thing to deal with is normal aging. So if you have someone who's 70 years old, I'm not talking about MS, just someone who's 70, they may not be as spry as they were when they were 30. They may not be as energetic. They may not be as cognitively quick. And that's just part of normal aging. So when someone is 70 years old and they have MS, there's a lot to sort through. Are they having difficulty with thinking because MS is getting worse, or because they're 7 years old? And so let's talk through that together. That's a great idea. Thank you for the suggestion. Now, I'm almost out of water here. And I haven't brought in extra, so I may have to run in the kitchen and grab some water. All right, let's look for some more questions. So Danielle writes, hello from Montreal. I love Montreal. It's probably one of my most favorite cities in North America. What do you think about Pyrrha? I'm 75 years old and I've never taken a DMT. Doctor wants to try me on it. So there's a lot of things there. So I want to talk about Pyrrha independent from your comment on age. So Pyrrha is not a disease-modifying therapy. It doesn't slow down MS. It helps with heat sensitivity. So if you notice, for example, that when your body gets overheated, your legs get weak and you can't walk very well, Pyrrha may buttress you against that. And in fact, Pyrrha can help with any symptom that's heat sensitive. It can help with cog fog. If when you get overheated, you have trouble thinking. It can help with some people, when they get overheated, their core becomes unsteady and they have trouble with balance. I have one patient, I love telling this story, who has heat-induced erectile dysfunction. So when his body heats up, he develops difficulty maintaining an erection, and Pyrrha help with that. And so I like Pyrrha a lot. If I hear that a patient has heat-induced difficulties, I will try them on Pyrrha. Pyrrha is processed by the kidneys, and so you have to make sure that you have good kidney function to take Pyrrha. Otherwise, you could hurt your kidneys with it, so that's a concern. And Pyrrha can lower the threshold for seizures. And so if you have a known seizure disorder, that's a no-no medicine. Now, you said that you're 75, and I don't think being 75 is a reason not to try Pyrrha. I think that if you don't have medical contraindications, meaning there's nothing medically why you shouldn't do it, then you and your doctor are willing to try it, I would try it out. And if you take it twice a day for a month and you don't notice that it's helping, then you might want to talk to your doctor about coming off of it. In my experience, people notice a difference within a month. Typically, it's a really big difference where they say, oh my gosh, it's really amazing. It's very, very rare, almost never, is someone kind of say, it sort of worked. It either was a really robust difference or it didn't seem to work much at all. So I think that's exciting, and I hope that you try it out if you and your doctor think it's a good idea. And if you do try it out, let us know on the channel. Write a comment and tell me what your experience was like. You know, there's 140 people online. That's freaking awesome. That's a lot of people for one of my live streams. So let me just say thank you. This is really exciting for me when I get a chance to interact with you guys. So thank you very much. And again, I just want to relish the fact that there's this growing global online village. That makes me feel really, really good. There's 46 thumbs up. If you guys like what we're doing here, please give me a thumbs up. It helps out the channel actually in the YouTube analytics. So definitely throw a thumbs up if you like this live stream. So, oh, it skips around here, guys. I'm sorry. I started to read a really important question, and then it skipped around. I'm going to paraphrase this question because I just lost it. I'm sorry. But someone said, I have secondary progressive MS, and the doctor said that there's nothing for me. There's no treatment for me. And that's bullshit. In the United States, if you look at the label for almost all the MS medicines, they're indicated for relapsing forms of MS. That includes clinically isolated syndrome, relapsing MS, and what they call secondary progressive MS with activity. And so these medicines work in secondary progressive MS. It's my opinion that just because you have secondary progressive MS, that's not a reason not to be on a medicine. It's my strong opinion that you should still be on a medicine because you still could have attacks and you might not bounce back very well. I'm sorry to use swear words, but I feel really strongly. And I do not think that it's the right move to take someone off a medicine because they've entered into secondary progressive MS. I think that's just absolutely wrong. All right, looking for other questions. So Shauna Ice writes, question, I have issues swallowing liquid. It hurts. What can I do? Well, you definitely 100% want to bring that to the attention of your doctor. People with MS can develop swallowing difficulties, and you can swallow down the wrong tube into your lungs, and that's a setup for pneumonia. That can become very, very serious, and you don't want to joke around about that. So I want you to call your doctor tomorrow, and I want you to tell them, hey, I'm having swallowing difficulties, and I need to get in to be seen. And specifically, I would encourage you to see a speech pathologist and have a swallowing study. Swallowing studies, there's ways that they can see exactly what's happening during swallowing. And a lot of times, behavioral techniques like a chin tuck maneuver, drinking through a straw, there's various things that can be done to help with that. So please don't let that go. That's something that needs to be looked at. So MS in the 11th percentile says, get more water. Love you. Guys, I'm going to run and get more water. Give me 30 seconds. I'll be right back. Don't go away. In fact, I'll keep talking so you can hear me. I'm going to run into the kitchen. And I'm already coming back. And I've got some more water here. All right. Oh, good. I didn't lose very many people. Thank you for that. Oh, that tastes good. All right. So here's a great question from Angela Morris. She writes, question, what are the chances that my son gets MS? It's something that really worries me greatly. Thanks again, Dr. Boster. Well, Angela, howdy, hi. In the general population, the risk of MS is not very high. So maybe 1 in 700 in the Midwest, maybe 1 in 500 in the Midwest. If you have multiple sclerosis, then your first-degree relatives have a higher risk of getting MS than the general population, but it's not sky high. So if you have MS, your son's risk of MS would be about between 1 and 3%. So between 1 and 3% is the statistic that I keep in mind. I think there are things that you can do to lower your son's risk. So let's talk about that. Smoking increases someone's risk to get MS. So you most certainly would never, ever want your son to smoke. And I would probably keep him away from secondhand smoke. So that's a really, really important one. The second one is that low levels of vitamin D seem to increase a given person's risk to develop MS. And so you can work with your son's pediatrician to check his vitamin D level. And if it's below normal, the pediatrician can recommend supplementation to push up his vitamin D level, which I think would be protective. Also, morbid obesity has been shown to increase the risk for MS. It almost doubles it in children. So if your son is morbidly obese or has a sedentary lifestyle, that's something else that you want to fight against. And so those are three things that you can do to help lower his risk. I do not consider MS to be a genetically passed on condition. There are some conditions where if you have it, 1 in 2 of your children or 1 in 4 of your children are going to have it. And that's not what we see in the setting of multiple sclerosis. So I hope that helps, and I don't want you to worry. So DF writes, is a CIS called a CIS only once? So I'm not exactly sure what you mean. CIS stands for clinically isolated syndrome. So the first clinical attack that seems like it's demyelinating and is a common attack in MS and could go on to become MS is called CIS. It's the first attack. Now, the definitions of MS require an attack and then some stuff, either MRI changes or a second attack or something like that. So I think what you mean is once you have a CIS, a clinically isolated syndrome, and then you have something else, what's no longer called CIS. So I assume that's what you're talking about. Common clinically isolated syndromes are optic neuritis, a brainstem syndrome, or a spinal cord syndrome like a transverse myelitis. So I'm going to butcher this name. Larkspur3 writes, I'm 62, on Tysabri for 9 years, just put on Pyrrha, and it's wonderful. That's awesome. I think that's fantastic. Good job and congratulations. All right, let's look for some more questions. Scrolling through this. So Chelsea Lambright writes, is there such thing as cold sensitivity instead of heat sensitivity? Yes. So I have a playlist on my channel about temperature-related symptoms. And people with MS can have certain symptoms if their body gets overheated. They can have different symptoms if their body is cold. The most common phenomenon that we see in the setting of cold is worsening spasticity. So muscle limb tightness, spasms, cramps, things like that. I've also talked to patients that have neuropathic pain that gets worse when they get cold. So yes, I do have some patients that have what appears to be a cold sensitivity. And they'll tell me that heat doesn't actually bother them too much, but the cold is just awful. I also have patients where they have problems both when it gets hot and when it gets cold, which is kind of not fair. All right, I'm trying to scroll through this. You guys have no idea how hard it is for me to scroll through this and not lose my place. It's like a super hard challenge. All right, let's see what I've got here. Justin has to go to bed. Justin, have a good night. I understand. So MJL1516 writes, hi, Dr. B. Do you see many patients that have a few brain lesions but have a lot of spine lesions? What DMT do you favor in those patients? So I do see some patients that have a predilection towards spine lesions. People with primary progressive MS tend to have more spinal cord lesions than brain lesions. Actually, African Americans tend to have more spinal cord lesions than Caucasians for some reason. And there are just some people that have very few lesions in the brain, but they have a lot of spinal cord lesions. So spinal cord lesions is a bad prognostic factor. It's not good to have spinal cord lesions. And I like to use the most effective drug they'll let me use in people with spinal cord lesions. So the monoclonal antibodies are where I would want to spend my time. Alemtuzumab, ocrelizumab, natalizumab. These are medicines that I would want to use. I would not want to put someone that has spinal cord lesions on a mild medicine like a Copaxone or like an interferon. I definitely would want to go for the heavy hitting medicines. And I tend to gravitate towards Ocrevus or medicines like that. So Zicae, I'm not sure how to say that. Zika, I hope I didn't butcher your name, says, I feel constantly thirsty no matter how much I drink. My thyroid and glucose have been checked. Is this caused by MS? So I would definitely want to work with an endocrinologist. If you haven't worked with an endocrinologist yet, that's where I would start. I have not had people with MS that have uncontrollable thirst, but there are other conditions like diabetes insipidus where people can have problems with thirst. That's not one that I've heard of. I'm going to have to do some research and look online about cases of people with MS to see if that's ever been reported. It's not something that I'm familiar with. Here's a great question. Ren Eberry says, question, do the number of oleclonal bands in the spinal fluid indicate prognosis? Do more equal worse? No. More does not equal worse. So it's not like if you have 10 bands, you're going to do worse than if you have 2 bands. That's not the case. So AJ's HR question, I've been down with my vestibular system for the last few months. I also have the shakes internally, connection to MS. So I don't know about internal shakes, but I do know about the vestibular system. So the vestibular system is your inner ear, and it's kind of a gyroscope. It tells you where your head is in space and where it's moving around. And the vestibular system can certainly get goofed up in the setting of MS. It's very, very frustrating. People can have vestibular attacks where they're super vertiginous and spinning. They can have other vestibular problems. It can definitely be related to MS because the circuitry of the brain that controls that gyroscope can become affected. So that can be super not pleasant. There's treatments for that. If it's an attack, we give steroids. I have a couple friends in town here in Columbus that are expert neuro-otologists. So they're dizzy doctors. And a lot of times they can help figure some things out. They use benzodiazepines and other medicines. And I hope that you're being treated for that because that's a terrible problem. Come here, River Dog. I've got my dog, River, here. Come here, River Dog. Let's say hi to everyone online. Let me see if I can get the camera. That's my baby doggy. You're a pretty girl. Can you say hi to everyone on the internet? You're so cute. Look at that great dog. Hi, baby girl. She was at the Pet Palace for the last 10 days or so when we were out of the country. And so I'm really, really happy to have her back at home. You're so sweet. Yes, you are. Okay, you want to go lay down? Lay down. Good girl. Sorry, guys. I love my dog, River. All right, let's look for some more questions. So 65 Fury 933022 writes, question about stress. How does stress impact MS? I work a high stress job with an average life expectancy of 55. Not sure that I should do that anymore. Change of profession, maybe? Well, 65 Fury, nobody goes home at night and says, honey, let's get stressed out. I mean, that's not something that anybody says. And I hate it when doctors say, remove the stress in your life, because I don't know how to do that. I do think that managing stress is very, very important. So I can't tell you whether you need to change your job. I can tell you that stress can exacerbate symptoms. That's certainly true. And I can tell you that learning to manage stress, I mean, literally participating in stress management classes, learning meditation, learning mindfulness, this isn't namby-pamby stuff. It can actually be very, very helpful. And so I would, at minimum, want you to embark on a journey to try to figure out how to manage stress as much as possible. If there are ways that you can minimize stress in your life, I think that can be a big help. I would hate for you to have to leave your job, but I really can't counsel you in that without knowing more information. But stress can worsen MS symptoms. I don't think that it necessarily can speed up the disease, but it can make symptoms come out and really be bothersome. So Angeli writes, question, how often do you see weight loss and muscle wasting in MS? I've had MS since 1997. I am underweight now and concerned. So I see it somewhat frequently. Oftentimes, the first thing that we look at is someone's diet. And sometimes people aren't taking in enough calories. And so it's worthwhile to meet with a registered dietitian or at bare minimum, track calories in and calories out. So for a period of 2 weeks, be religious about writing down everything that you eat and look at the average calories. And what you might find is that you're not getting enough calories in. Also, a lot of times people aren't getting enough protein in. And one thing that's easy to do if you're underweight is to add Boost or Ensure at the end of your meals. So Boost or Ensure are these little drinks, there's like 8 ounces. And I don't want you to have them instead of eating. I want you to eat a normal meal, but then I want you to finish one at the end of your meal. And those are very high calories, very high protein content. And so I would literally add one after you eat a full breakfast, after you eat a full lunch, and after you eat a full dinner to make sure that you're getting adequate nutrition and calories. This is a good thing. If you keep a log of what you're eating for 2 weeks, bring it to your doctor and show it to them and say, am I doing okay? And if you have more questions, then you can ask for a registered dietitian to meet with you and go over all that stuff. All right, let's see what else we've got here. So Barbara Rice says that her dog is always by her side. That's her baby and loves her constantly. I definitely feel the same way about my dog. All right. Let's look for some more questions. Delaney is online. Hello, Delaney. Question. Do you encounter a lot of MS patients being abandoned by their partners after a diagnosis? Asking for a friend. So Delaney, there is a double likelihood of being divorced if you have MS. So that's really high. And I have had the experience many, many times with people that I care for with MS that partners can leave. Now, I have many experiences where partners are fantastic together and they have a strong bond and they help one another. But it is a real concern, and it's a sad thing. I think that open communication is the critical element here. I think that concerns and fears need to be brought out as soon as possible and discussed. And I also think that making sure that the person with MS has an adequate support system is really important. So you don't want to put all your emotional support in only one basket. I want you to have a care partner, but I also want you to have a village. It's a real serious thing. And so I hope that your friend's doing okay. And I hope that your friend has a support system. And thanks for sharing as always. I love when you write on the channel. So Melissa writes, are heart issues connected with rituximab? No, not to my knowledge. I am unaware of B-cell killers impacting the heart. All right. Oh, I see Damian Washington's online who writes, peace, doc. Damian's a cool guy. Damian is a guy living out in, I think, Los Angeles, out in California. He's an actor. He's got a YouTube channel. He has MS, and he's pretty funny. Earlier this year, he did a rap about MS that was real big on Twitter. So check out Damian Washington if you have a chance. He's got a really fun YouTube channel. All right. We're winding down here. I'm getting pretty darn tired. And so let me answer a few more questions, and then I'm going to jump offline. So the 11th percentile says link. If you go to my my channel under supported channels or highlighted channels, I have his channel listed, so you can find it there for sure. And Damian, if you're still online, go ahead and throw the link up to your channel if you don't mind. I think I'm caught up on the questions. So this has been a really fun 50 minutes. Thank you guys for jumping online with me. I just got home from a big trip overseas. I was at the ECTRIMS meeting. I live streamed about that last week. Then I went on a big family vacation where my sister-in-law got married, which is pretty exciting. I just got home this evening. My family's upstairs in bed, and I wanted to spend a few minutes with you guys. Thank you for jumping online with me. There's 91 thumbs up. There's 152 people online. This is just absolutely fantastic. I love this growing online village. My name is Boster, and as always, I want to thank you for learning about MS with me. I try to do a live stream once or twice a month. It's really fun for me. I love doing it. I also try to put out a video once or twice a week. And so I love your comments and your questions and your participation. And if I didn't get to your comment, please don't fret. When the live stream's over, I read through everything, all the comments, and I copy and paste them and keep them. And I'll either address them in a future live stream or in an upcoming video. So be good, have a wonderful week. And until the next time I see you on the internet, take care.